I'm John McKenzie, Chief of Pediatric Radiology at UCSF, and I am delighted to present to you Making the Dose Count, ensuring the most accurate imaging in children. I have no disclosures. What I will present to you today is a recipe for reducing the dose while maintaining excellent image quality. Simple things we can do add up to reductions in dose with often improved image quality. First, an overview. The challenge we have with dose reduction is, at first, it does not look simple. We have many choices to make when optimizing our CT scan protocols, many knobs to turn on the CT to fine-tune scan parameters. And it is a balancing act between dose reduction and image quality. Second, our patients are challenging. Kids move and they don't often follow directions. However, movement can magnify poor image quality in low-dose CT imaging. Third, it takes an enormous amount of teamwork to get the child and their parents through the process of a CT scan. Multiple players need to be focused on image quality and dose reduction and not distracted by lack of teamwork or other priorities. We have a lot riding on doing this correctly. The public is keyed in on CT and possible links with cancer. This is magnified when considering children. Unfortunately, the long-term risks of CT scanning in children are not known and largely theoretical. To really know the long-term risks and association of CT scanning with cancer would take an enormous amount of patients to study over an entire lifetime. Regardless, the public concern is real. Our choices also affect how we work as radiologists. If we bow to the pressure of a low-dose protocol at all costs, we end up with less reliable studies. Shown here is a pulmonary embolus CT study with a simulated low-dose protocol. And I challenge you to confidently say the patient has a pulmonary embolus. We'll return to this case a little later. So the recipe for success for reducing dose while maintaining high image quality boils down to three areas. Technical parameters optimized on the CT scanner, a system for efficiently and confidently helping pediatric patients through a scan, and a team focused on making this happen effectively. Let's focus for a while on the technical parameters. Here are the important technical parameters for low-dose imaging with high image quality. Number 1, you need PED-specific CT protocols. Number 2, you need access to new CT technology. Number 3, you need to optimize oral and IV contrast. Number 4, you need to be aware of special situations unique to CT in kids and navigate these situations with low dose and high image quality. First and foremost, CT scanning with low dose and high image quality can only be achieved with pediatric-specific CT protocols. Typically, the weight of the patient is used to modify CT parameters, since weight correlates fairly well with differences in body size, as shown here in the differences in the adult, 8-year-old, and infant hands. The main parameters that need to be adjusted that most affect dose are the tube voltage and tube current. We can titrate these as shown here on this growth chart. Here is an example of how we titrate the tube current based on the patient weight. The pediatric growth chart is overlaid to show the relationship between age and weight and how this corresponds to tube current. At UCSF, we use a color-coded system adopted from how we select medications for children based on size. Each color corresponds to a different weight of the child. Once the weight of a child is known, the appropriate protocol is selected by the CT technologist. You can see here how the tube current and voltage are titrated based on weight. Other parameters that are optimized in this protocol are pitch, slice thickness, and gantry rotation. This is actually a real bonus to us at UCSF. The pediatric radiologist protocol is a pediatric abdominal protocol, and the rest is black boxed. It takes the guesswork out of protocoling and makes for a more reliable and reproducible CT scan. We also rely on automatic tube modulation to vary the MA based on the density of the patient in a particular area of the body. Areas of the chest with lots of lung have lots of air that does not require as much current to produce good images, while the increased mass around the shoulders will require more current and often results in us hitting the ceiling in terms of how much dose or protocol is designed, as is shown here. This is an example of the difference between an optimized and unoptimized PED CT protocol. The scan at your left was obtained by guesswork. The scan at the right was obtained by following our color-coded weight-based protocols. It's clear which patient got a diagnostic CT. Now, which one got the higher dose? Certainly the one on the right. But the dose is still low and provides a scan with exquisite image quality necessary to make a confident and informed diagnosis. Our second parameter that we can control is the CT technology used to scan kids. At UCSF, we send our youngest patients to our newest, most modern CT scanner because it has the most advanced hardware and software. It's fast and has some great dose reduction technology. New iterative reconstruction technologies are now offered by all the major manufacturers. They all offer some form of advanced reconstruction. Moving from conventional backplane to iterative reconstruction can give back enough image quality to scan at a lower dose, at least 30% lower dose. One new advance in reconstruction technology that we offer our patients is imaging with model-based iterative reconstruction. Compared to the more conventional ACER reconstruction, the model-based approach shows us more anatomy. In our younger patients, we see more branch vessels and are able to visualize vessels farther out in the periphery. We also see a statistically significant greater number of vessels and smaller vessels. Here is the right renal artery reconstructed from the same scan in a 3-year-old. On your right is the ACER volume rendered data, and on your left is the model-based iterative reconstruction. Here you see with the model-based more branch vessels and smaller vessels. This is at equivalent doses. The next step for us is to now lower the dose with this new iterative reconstruction technology. We have reduced our doses by 40% using this strategy at UCSF and anticipate that we can go even lower and expect a 60% reduction. Here's an example of how we use this reconstruction technology for pectus evaluation. We scan our patients at the lowest scanner setting possible, 80 kVp and 20 MA. And here's how low we can go in terms of dose. The suggested dose for a routine adult chest is 5 to 10 millisieverts. We typically scan our PEDS routine chests with good results at 0.5 to 2.5 millisieverts. Our CT for pectus is only 0.2 millisieverts. Compare this with a 2-view chest at 0.06 millisieverts. We're getting closer to the reality of very reduced dose CT protocols. Now let's focus on optimizing oral and IV contrast at low dose CT. Factors that wipe out any benefit of low dose CT protocol are poor IV and poor oral contrast, as well as motion during the examination. I will show you examples of these. Here's our goal. On your left is the original scan at an effective MAS of 90. It's easy to see the pulmonary embolus in the right lower lobe. Now, if we simulate at low dose a scan using an effective MAS of 10, we still see the pulmonary embolus with a high degree of diagnostic confidence. Look how good the IV contrast is. It is dense and clearly defines the embolus. Now look what happens when we try lowering the dose with poor bolus timing. We can make out the embolus on the original scan, well, just barely. but is essentially hidden on the simulated low-dose scan. This was consistently missed by our blinded readers. Poor bolus timing is a recipe for disaster on low-dose CT imaging. Let's turn to this example of how oral contrast material might have helped us more confidently diagnose bowel inflammation. This is a 7-month-old with a fever and neutropenia after bone marrow transplantation. The patient is moving during the examination, and before the exam, they had a hard time giving the patient oral contrast. Several things here make visualization of the bowel wall difficult. Number one, the child has inherently little intra-abdominal fat. This is true of most children of this age. Number two, the scan is using a low-dose protocol. Number three, the child is moving. I argue that good luminal contrast would have helped delineate the bowel. The diagnosis was confirmed by ultrasound. Let's turn our attention now to several special situations where we can save dose in pediatric patients. The first is minimizing repeat scans. Children generally do not need a repeat or multi-phase CT. Here's an example of 3 scans perfectly well. Why do we do multi-phase CT in children? Well, basically, it's because adults do it. There are very few indications for multi-phase CT in children. At UCSF, we try to push the vast majority of our vascular work either to MR with dynamic contrast enhancement or ultrasound. It is also well described that a second phase is not helpful in pediatric trauma. Also, overscan should be eliminated in pediatric CT. When scanning the chest, abdomen, and pelvis, one approach is to first scan the chest, then perform a second scan of the abdomen and pelvis once the contrast has reached these areas. This results in a double the dose of radiation in the overlapping area indicated here in orange. The preferred approach is one pass. This one pass eliminates this double dose. We do have suboptimal timing of contrast for the chest portion, but this is rarely a problem, since the indications for these examinations is generally tumor or infection. We also dial down the dose when performing CT-guided interventions. Here's the diagnostic scan prior to placement of the needle with scan parameters as shown below. Our subsequent passes are performed at a very low dose, often the lowest dose the manufacturers will allow. The dose savings here is tremendous. Often we achieve a 95 reduction in dose, and our ability to target the lesion and obtain good tissue is not compromised. Let's now focus on the patient side. Here are the factors to consider about the patient that help in dose reduction while improving image quality. Basically, it all centers around the patient and stopping them from moving. Kids move, and they don't sit still and they don't cooperate, particularly in the radiology department. You see here what happens when the patient moves? This image is of a 1-month-old and it's motion degraded. First and foremost, we ask our anesthesiologist to help. This obviously adds time, cost, and a risk of the anesthetic. But when the stakes are high, the only way to ensure an adequate examination is to anesthetize or sedate the child. We also benefit from breath holds by the anesthesiologist, which helps us reveal lung pathology. Child life is an important component too. This specialized team is a helping hand that works with families and parents. Child life prepares the child for the imaging examination, reduces fear and anxiety, and improves throughput. Child life also allows radiologists and technologists to focus on the task at hand rather than spending time dealing with a crying and moving child. Our experience is that child life also reduces the need for radiology studies under anesthesia. The environment in the radiology department is also key to a better patient experience. This underwater theme designed at Lure Children's Hospital transports kids to another world. Unlike the stark and sterile environment of most places in the hospital, when kids enter this setting, they cooperate more often. Please hop on the submarine. You're going for a ride. Oh, the submarine is going underwater. Hold your breath. The final ingredient in the recipe for dose reduction and high image quality is teamwork. The radiologist, nurse, CT technologist, child life specialists, and support staff need to make it a goal for dose reduction. The team must recognize the potential to improve. The head needs to come out of the sand, and we need to fit all, especially for imaging kids. Kids are not small adults. How to work together is like any other group function. You form a team, work on good communication, and set goals to recognize success. At UCSF, we formed a radiation safety committee. The group is responsible for evaluating our processes, identifying problems, and forming solutions. One of the primary tools we have is the CT dose report. We use this metric as a report card and are now required by California law to include the dose delivered in our official CT report. We also have dose monitoring software that we use to chart trends. It also alerts us to events that are above a certain threshold. This approach allows us to target change. We find that we optimize our color-coded protocols about every 6 months. In summary, we have reviewed specific strategies for low-dose, high-quality CT imaging in children. We have a focused CT technique, optimized patient experience, and we form a team approach for monitoring and improvement. Simple things do add up. This recipe for success results in a reduced radiation dose and improved CT image quality. It adds up to big results. First, use pediatric specific protocols that are based on weight and body part. Then implement processes that facilitate imaging of children in a rapid and safe manner. And finally, adopt a team approach with the goal to improve. It's a winning combination. Thank you.